Welcome, listeners, to Health Tech Night, episode 3. I've got Justin Reynolds here, who's a consultant in healthcare, currently works with Rebalance MD in Victoria, BC. And I've got Chris as well, my co-host, and myself, Jason. Thanks for joining and listening to Health Tech Night episode 3. We thought we'd start with a little bit of a recap on our most recent Health Tech Night, which was that, Chris, 2 weeks ago?
Yeah, a couple weeks ago, had Jordan from Care to Talk, and there's probably about 50 people, even though there was the threat of snow, which always makes me laugh, and Justin, probably you too, coming from Alberta, which we will talk about. Good discussion. It was at Viatech, so room was full, and I think we were trying out a couple different scenarios in terms of room format and things like that. You kindly let me jump up on stage, which was a lot of fun. The one step up there, so that was good. And I really just focused on how Care to Talk's kind of come to market, the different things they've done in the PCN space, and there was lots of good discussion. I think that was probably the best part of it. Was the audience was pretty engaged and lots of different questions that were being asked. So hopefully the next one, which is coming up in next week with Vancouver Island Life Sciences, we'll get a good turnout as well. So Health Tech Nights is popular, which is good to see.
Yeah, it's definitely it's got a life of its own. We got an article in Victoria Tech Journal too, which was cool. Yeah. Big shout out to Viatech for letting us host in their space often. So thank you, Viatech.
Maybe talk a little about that, the article that you did and the interview that you gave.
Yeah. So again, like for those who don't know, we started Health Tech Nights in early July, June 2022. That was the 7th Health Tech Night we'd hosted. We've tried a couple of different formats. The kind of theory around Health Tech Night is we're bringing together healthcare entrepreneurs, we're bringing together tech entrepreneurs. When I first started a health tech company in Victoria, I realized there was very little community built around health and health tech, and really wanted to find like people with a similar mindset in Victoria. And I think we found that, and there's quite a few people that come out. I think we've had like over 300 attendees, unique attendees in the 7 Health Tech Nights, and a lot of them are like repeat offenders. Like they're back every single time, and really great conversations. And I definitely come away learning something new every single time, which is great. So I think there's going to be a lot of like good things that Health Tech Night has happened in the next few years here.
Yeah.
We're incorporating it into a nonprofit society soon, so it's going to be a little bit more legitimized, and we're gonna have a board and stuff, so that way we'll be able to have sponsors and then kind of give back to community and grow Health Tech Night. So yeah, I'm really excited for the growth, and there's a lot of good things. We've had a lot of sponsorships.
A lot of interest,
yeah,
all kinds of interest coming out, which is good. So,
any opportunity to take that into the U.S. as well, and across Canada?
We'll see. I don't know. Did you read our business plan or what?
Yeah. What are we pitching to VC here or something? What's your U.S. plan?
Yeah. Are you interested in sponsoring?
I might be. There you go.
I think that's the cool thing, is lots of opportunity for sure.
Yeah.
And that's how we first met. Actually, it was at one of the first Health Tech Nights. So, you were what was that? Number 2 or 3?
Yeah, number 2. Yeah, on the rooftop of 818 4th Street.
So you're one of the few, for the first probably, to be Health Tech Night and Health Tech Night podcast.
Oh, wow.
So
yeah,
down in the Hall of Fame
I feel
forever.
Special.
Right on. Well, let's jump into it. Okay. Justin was going to. So I don't know if you don't know Rebalance MD started as an orthopaedic clinic in Victoria. It's like the largest specialist clinic now, like at least on the island. I don't know if like in BC.
Sure. Yeah, it's probably one of the largest, large orthopedic clinic nationally, I believe now, with 50 full-time physicians, specialists. So it's certainly grown to all different facets. 2 new rheumatologists just recently started as well, so it's certainly growing on all different areas.
You guys got cardiologists now too?
Yeah, full new cardiology division, so that's now has 11 cardiologists and another 4 joining, so trying to get everybody in town to join.
Physio, bracing, everything
right. From musculoskeletal care, so the physio and bracing side of things, and then on the cardiology side, have in-house halters, treadmill tests, things like that. It's all different cardiology related products.
And maybe just talk a little bit about what your role is there. Like you're a consultant, you also got a lot of previous experience that's helping with the role, but what are you doing right now and sort of what brought you to this point?
Yeah, so I was brought on board to kind of grow Rebalance in terms of different divisions, so as well as managing their profit centers, so non-medical related products, so things like the one bracing side, the physio side on the musculoskeletal business, and now open up the cardiology division. So now managing what they call their tech side of the business, which is all the halters and treadmill tests and things like that, selling blood pressure monitors and things like that. Everything non-medical related. So medical related would be classified as all physician MSP type billing products. So it's basically brought on to grow that side of the business and open up new divisions. So certainly lots of discussions into Vancouver, and of course over into Toronto as well. So, but right now we just finished opening cardiology a couple months ago. So that's been the newest addition to the clinic.
And how did you get to this spot? Like you've got some healthcare experience, you're an entrepreneur.
Yeah.
Maybe just give a little background, because I think a lot of your perspectives are unique in a case where you're not just from the healthcare sector. You've got a lot of other areas that you're bringing from.
Yeah, so certainly I moved to the island, I guess about 4 or 5 years ago now, and I sold my business in Alberta. It was in the construction business, and came over here and ended up buying a medical supply business locally, and it was a bricks and mortar, and owned that for a couple of years, ended up selling that, and in the meantime I was in an entrepreneur network, entrepreneur organization, and I was in a forum with the CEO of Rebalance, and when I was selling the retail business, he had asked if I'd want to come in and join when he's in the process of selling a portion of his business to a VC. So that's kind of how I got onto the Rebalance side, and brought on to basically grow, like I said, all their non-medical side of the business.
Very interesting. So let's maybe chat a little bit about the Rebalance and the state of surgery in general.
Sure.
Maybe just don't worry about the light. It's okay. Maybe just give us your thoughts. Like, what are the biggest challenges right now from a surgical workflow perspective?
The biggest issue right now certainly is surgical wait lists are growing, and that's due to cancellations in the hospital. So cancellations are occurring, probably around 20-25% of the surgeries currently are being canceled due to lack of staffing, primarily nurses in the OR, and post-surgical care as well in ward unit. Even daycare procedures are unfortunately getting canceled as well, which is not ideal for patients. So patients historically were waiting pre-pandemic were 2-3 months. Rebalance went from 18-month wait list down to 2 to 3, and now they're back up to 9-10 months for sure to get into for surgeries. That's once the surgical decision's been made.
So if you're getting like a hip or a knee or an ankle or whatever, like what do you expect to wait for like a non-urgent operation like that? From
your what we call wait 2, once wait 2 has been identified, so once the surgeon's made that decision that you need surgery, then it's anywhere between 9 and 12 months right now.
It's a long time.
It's a long time.
What does the quality of life look for those people if they're waiting for a hip or a knee or whatever?
It's certainly not ideal. They need to be seen. They need to get those joints replaced. It is still obviously Island Health wants all their orthoplasty side of the business, which is of course their total joint replacements to be done primarily as a focus, but it's just the lack of staffing, and they try and book it out and then they cancel. So now we've just scaled back on our bookings completely because it's just it's more of a logistical nightmare trying to cancel everything as opposed to just not book them at all.
And what are people's options? Like, can you go to the US to get these surgeries done? Like, how much does that cost out of the pocket?
Yeah, certainly you can do that. Obviously there's a few Americans went down to Mexico last week, I believe, and were captured. So probably not ideal to go into Mexico right now for healthcare, but certainly it's an option to go there. There is some private stuff in Alberta, Toronto, and in BC's Vancouver as well. So there is those options, and those options are significantly less, but in terms of wait times, but cost-wise, you're probably $25,000 plus for a joint. So.
I don't know, that strikes me as like not that crazy. Like if somebody's waiting 12 months, you're immobile, you can't function, you have no quality of life. Like what's $2,000 a month for those 12 months in order to get that work done? Like, obviously it's not ideal. Like, it would have been better if like the system could deliver what these people need and what these people have paid for in taxes their whole life. But $2,000 a month for 12 months, could be worse.
Certainly breaking it down that way, it could be a viable option for many more people.
Yeah, definitely.
Is that like a line of business that you guys have looked into?
We've tried to stay away out of the private side of the business just because we are an Island Health partner, and being an Island Health partner, obviously the current government in BC wants obviously public health care to be prime focus. So it hasn't been something that we've kind of gone down. Certainly, I think it would be a nice outlet valve to ensure that patients can be seen on both sides, but realistically right now, until we adopt more of the Australian model, I think it's going to stay primarily with public health care for sure.
So maybe dive into that a little bit. Like you said, Australian model, is that the ideal state if we compare ourselves to what they're doing?
I think we're going to need both for sure. I think an opportunity just for staffing requirements, I think to pay some nurses potentially more, and so we have to charge patients more, which would increase flow through. I think it's just definitely, there's not a lot of other routes right now. They just can't create enough nurses to fill the shifts right now, and I think we got to get creative and bringing nurses in overseas potentially. I think also doing some incentive plans potentially to try and bring more in. But right now, that's certainly the bottleneck. There's just not enough staff in the hospital.
How are the surgeons feeling about this? Like, obviously, if they're getting their surgeries canceled, like, they might be pissed that they're not able to bill and they're not able to do the surgeries and get paid for them.
Yeah, certainly there's a very large frustration, especially in the total joint people. They've had canceled the most probably. But certainly there's not a lot they can do right now. It's just we're at the mercy of Island Health and government of BC right now to try and find a solution. There's not a lot that Rebounds can do because we don't run the hospital, so there's nothing we can do to.
Yeah.
We've removed their surgical bookings years ago, so we do their surgical bookings, which has increased efficiencies, which have brought on a wait list. But other than that, there's not a lot we can offload out of there to kind of for surgical.
So what does that dialogue look like? Like they're talking about staffing as the major barrier. At the end of the day, you guys still have patients. You guys are still trying to run a business and have no control over the amount of staffing that's in there. So what are you guys trying to do to help to influence or support or motivate Island Health, the government, to make change?
Well, I think we've offered to assist them more on some even their other small surgical centers. We can provide additional resources to them to try and increase some workflow, but it is tough. It's tough because of the union environment. It's not that easy, and I can appreciate where they're coming from. That the union kind of doesn't want to lose union jobs, although there's more jobs than people to be had. So it's a very slippery slope for them as well.
Well, yeah. Even in one of our health tech nights, we spoke to somebody who was in Island Health, like entrenched in a management position, and the union was grieving iPads being used at some vaccination centers because they felt like the iPads were taking union jobs. So like when you have that type of mentality in an organization, like where do you even start, right? Like that's just you can't argue. It's hard to argue with that kind of stuff, right? Like let's not use iPads because they're gonna make it better, but we've got nobody to put in these seats anyways. So like what are we really arguing about here, right?
I think sometimes it's a moot point because really and truly there's way more jobs than people, so I think they got to get more efficient, and until they get maybe on the same team, it's tough. They're currently always fighting against each other.
For sure. So I know part of your role was looking at different ways of making your internal operations more efficient. So maybe focusing on what you guys are doing internally from like a tech perspective. What kinds of stuff have you implemented over the last year and a half that you've been involved to help with that?
Certainly the bracing side of the business, we've automated all our scheduling. So scheduling has been a big thing. So it's basically an add-on to one of our softwares that we use, and so that's been exceptionally well. Also, we've moved a complete new system into Lightspeed, which is our POS system, which has been significant improvement on tracking margin tracking, of course, sales tracking, having the right inventory, so we've increased inventory significantly to make sure we have the products when the physicians need it for their patients. So that's kind of a lot of the main things we've done for sure there in terms of that.
Okay. And I mean, a lot of or portion of the folks that would be listening in are entrepreneurs that are trying to sell into the healthcare system. A big part of that, and what you just described, is adoption by the physicians or staff that you have. What are some of the common challenges that you face when you guys are trying to put some of these new systems in?
Well, I think right now, I think people need to really look at how you can replace people in clinic. And replacing people in clinic would be a massive windfall for any clinic. So if you can do that in a cost-effective manner. So for example, we have someone all day long that they just read faxes. And to me, that's just, should be automated completely. I mean, the healthcare, everything has to be faxed still for privacy rules and so on and so forth. But realistically, there should be a tool to be able to automate that so that it doesn't have to have a person doing it. And things like that, I think, and then little things like, I'd like to see, almost like a check-in booth, an automated check-in booth where you come in and, my name's so-and-so and, please go to pod A or pod B or whatever the area is, and kind of automate that through floor lighting. And I think tech has to be a part of the solution going forward in terms of minimizing patient interactions with people in clinic.
Yeah, like one of the issues is, like, a lot of that technology does exist, but maybe it's not like fully data compliant. Maybe the servers aren't housed in Canada. Maybe it's not specifically designed for medical use. And I feel like a lot of the business owners, the physicians, and even the pharmacists like myself, I could utilize some of this OCR, robotic process automation type software they use in banks and everything. But the hesitancy of what if it isn't fully data compliant? What does that look like for the entrepreneur? And nobody wants to take that risk because there's no real direction being provided by the authorities on hey, there should be measured risk taking here, because we're really at that point where patients' lives are suffering because we're not able to take that level of risk, and there's nobody to fill those seats.
I also think that the government needs to maybe incentivize these entrepreneurs to take those risks to do that, because at the end of the day, they're controlling the current healthcare system in the province, and if they maybe encourage more tech to be done, I think it would help with flow.
So for both of you guys, you guys both are operating these businesses that could implement this stuff. I mean, I deal with this all the time with clients and stuff, but how do you even go about that? I think it'd be interesting to kind of dive in to say how do you identify if there's risk? Because I think a lot of it is just perceived risk. Maybe it's not even there, but how do you even start to take a look at making a decision on implementing something?
Well, I think it's tough because there isn't really clear direction. When you look up, PAPITA, or you look up, Protection of Privacy Act in BC, it's or FOIPA, and people are throwing around all these acronyms, and as the entrepreneur, it's really difficult to access the information, figure out where you fit, and then figure out what are my responsibilities in here. And it seems like no governmental organization wants to take the risk to provide an extra level of information, to actually educate the entrepreneurs. So the entrepreneurs are taking a no risk stance. And the other thing too is a lot of these projects, which we could easily do, Justin and I were in the Forum and Entrepreneurs Organization. We had somebody come in from Toronto to talk about robotic process automation and implementation in all of our businesses.
Right.
And those are $25,000, $30,000, $50,000 projects, and if the government isn't funding healthcare in the way where these businesses can take a $50,000 risk or take a bet, that might pay off big. Everyone's financially risk averse too, right? So I think the answers would be provide additional information, try to educate the entrepreneurs, and then don't underfund the private side of healthcare. So then they're able to take these bigger financial risks. So that's really where the innovation is going to come from. That's going to allow us to increase patient throughput, increase patient quality of life at the end of the day.
Yeah, it's funny you say that, because that's the organization I actually went to do an automated fax reader, and they gave us a proposal, and the proposal was about $150 roughly to get that done. So we also want to take that bullet of cost-wise, so they went to TELUS, essentially, and so TELUS is now currently developing it within their current product of Input Health. So now it's been a year and a half waiting for TELUS to develop it, and they're apparently launching it this month, or testing it this month. So we'll see how that goes, but that's kind of was, you know, one of the ideas I brought forward to automate. You know, that's one of many, I think. I think, you know, you look at nowadays, in everywhere you go to the grocery store, you know, there's no tellers, it's self-checkout, everything's putting all the onus back on the customer. And I think, unfortunately, to increase throughput and efficiencies in healthcare, I think we got to do the same thing in that side of the business as well. So, you know, we can't have interaction. It's got to be an automated. So sign themselves up, you know, automated bookings, whatever you need to do. I think we need to, unfortunately, force patients and customers to do what everyone else is doing, banks, everywhere.
Well, and I think like the patients and the population needs to take a level of responsibility here too. Everybody kind of wants to be like spoon-fed the next step and everything, and like there is a lack of information out there, so it's not entirely clear what a lot of patients should be doing next. But I think anybody that can advocate for themselves and can navigate the system should navigate the system. For sure. Because there is a percentage of patients that can't and are unable to, and those are the ones that we should be helping, not the people who are like, you know, willfully ignorant and don't want to do the work and put in the work and take the next step and even take like the preventative measures that they should be taking in their own life to make sure they don't need or require a lot of these interventions. And I think like, you know, it's a little bit of everybody's fault. Like, I think private sector could be doing more. I think the public sector could be doing more. And I think like the patients and the population could definitely be doing more too.
So you guys are both in an interesting position where, you know, with the pharmacy side and with the rebalance clinic, you are relying on government, but you're also playing that sort of intermediary role between the public system and the private system. So how are patients reacting to stuff like that? Like if you were to say, we're going to charge, you know, $5 extra to everybody that's coming in, or you know, a fee on every prescription that's refilled in order to get some of these different solutions to be more efficient, how are your clients going to react to that?
I think it'd be a 50-50 split, unfortunately. I think younger generation will probably for sure, you know, probably pay a little bit more to get better service. But the older people that have had free healthcare for their whole lives, I think, are going to struggle. And primarily on the orthopedic side, your older patient population. So I think it'd be a bit of a tougher sell. I think it should be offered, but again, it's tough for Rebalance to go down that road, especially on the medical services side for sure. But the other stuff, you know, obviously physios are private pay, and of course any sort of the bracing, splinting is all private pay as well. So
it's you know, like payment for healthcare in Canada is like a very, very difficult topic. You know, people don't even want to pay $1 for a lot of the services that we offer, right? Like they want everything to be 100% covered, or their copay's $2, and they're not going to pay anything more than that $2. And it's you know, it's tough for the businesses too, because like we're stuck in the middle. Like we're paying the staff, which has just been like incredible inflation. You know, the government hasn't inflation adjusted anything that they're paying physicians or pharmacists or anything, and then the patients have incredibly high expectations. So you're kind of stuck in the middle, and like we could definitely be doing more if we had more resources, but like where are those resources going to come from? I think the government's like, they got a lot of priorities, and they're not going to be like, you know, increasing pay by 25 or 50% anytime soon. Sure. So I think like, you know, the patients definitely need to realize that like, yeah, there are businesses on the other side of this table, and like they need to work in order to give them the services that they need. And at the end of the day, right, this can't be off the backs of the entrepreneurs. And I think like that's the way it's trending, and that's just going to lead to like an unsustainable environment for everybody.
It's been very tough to operate because your costs through the last 12 to 24 months have been to skyrocket, and yet the MSP billing fee guide has not followed suit. So I mean, the revenue coming in the door is not increased, but your costs have gone through the roof. So you got to try and squeeze the difference somewhere else, and really I think it's just going to have to do with automation and minimize people.
Right. What about the changes that were announced in the new compensation side? Like, do you see that helping anything? Well,
that's on the GP side, the family practice side, and not on the specialist side. And I think I unfortunately think it's going to make it worse.
Okay.
I think definitely, there's two problems. There's access to care, so just patients didn't have any physicians to see, and I think the other problem for GPs was they weren't compensated enough for their services.
Right.
So I think they've addressed one issue of compensating them more, but having so many patients on their roster now, they can essentially now just kind of call it fire a whack of patients now. So it's going to create more patients looking for physicians which are not available. And so I think it's unfortunately I haven't seen the where it's going to land yet because it's still so early, but I think it's unfortunately probably going to make it worse.
So what
attracting physicians though, short long term it should bring more physicians in. I mean the pay in an Alberta physician versus a BC physician is significantly different.
Sure.
So they're trying to close that gap is what BC's trying.
Well, and like Alberta's a great example, right? Because they have less physicians per capita than BC, but they don't have a physician problem.
That's right.
Like I don't know if it was Calgary or Alberta, but Calgary or Edmonton, but one of them had 300 doctors taking patients, right?
Yeah.
I don't think you could find a single doctor taking patients in Victoria.
No, it's not. It's like a 7-year wait. I mean, you moved here. I just moved here.
I have no GP. Yeah.
I've got no GP either. Like we're paying for services now.
And then now, you jump on TELUS Babylon to get on for a GP. I mean, you're waiting 2-3 weeks even. You can't even get in.
Yeah.
In a few days. But that time you're
exactly
more issues.
And then also you have politicians attacking like the Maples of the world, who are like providing some level of service.
Yeah.
And like, as a parent, as a somebody who's got to see a doctor, or you need your kid to see a doctor, like, are you really going to go drive around to 50 different walk-in clinics and spend half your day like waiting in line, maybe to not even see a doctor at the end of the day? No, you're going to pay $50, right? So like I'm appreciative of the Maples of the world, and I think they're being given a really hard time. Like they're the ones that started this problem, but the reality is like they're only like trying to patch it. At the end of the day, the power really falls into the politician's hands.
I do think that we do need to give more opportunities for pharmacists to do more as well. That would
April 1st, man.
Did he tell you to say that?
Yeah, he did not. That's one, and then physician assistants is another big thing. Allow those to be legal in BC.
Yeah.
I mean, the U.S. kicks out a lot of them every year, and they use them all over there. You can go to a physician assistant walk-in clinic.
Yeah.
And they have their prescribing schedules, but a lot of ailments can be seen by physician assistant. If they even let those people see, that would help family practice significantly.
For sure. Or the NP model, like that's what we do is we see an NP. 95% of the things that we need can happen there, and if not, there's a referral that happens. But I probably had more interaction with the healthcare system in the last 6 weeks than I have in the last 10 years, just because there's someone there that can do that now. So scope of practice changes for everyone, not just pharmacists. I know you like that.
So April 1st. So like that's good. 4 weeks away. We don't know what's going to happen exactly, but we know it's probably birth control. It's going to be urinary tract infections, like skin care, fungal infections, eczema, etc. So. In Alberta, I think it's pharmacists. Out of the 55 million prescriptions that were written, about 1.8 were written by pharmacists. So something like, just over 3%, which I think like in those emergency situations, and that really helps people out.
I also think you're going to see higher percentage-wise. There isn't a shortage of physicians in Alberta, where in BC, patients have no options. They'll go to a pharmacist now.
Well, and like a pharmacist, like they're not a qualified diagnostician, but infinitely better than no care at all.
For sure,
right? 100%. Like what's the word? What's the phrase? It's warm beer's infinitely better than no beer at all. So, I think scope expansion is really important. And I'm not advocating for pharmacists to do something they're not trained to do, but they're trained to do far more than they currently are allowed to do. So I'm excited for it.
So what are you guys seeing, when you talk to the physicians that are working with you? Are they interested in seeing, and I know you're more on the specialist side than on the GP side, but what are they thinking about, the expanded scope and things like that?
It doesn't really affect any of the specialists, so they haven't really said much. Obviously, there has been some GPs that have been vocal. There's been a few specialists in town that have been vocal, I guess, about pharmacists increasing their scope, but I certainly am for it. I think it's necessary. I think there's a lot of patients that need to be seen by specialists that can't get referrals. and
Right.
even going as far as that potentially to maybe increase referral options for patients as well, I think would be another increased scope that could be. I know sometimes the physicians don't love the referrals that come in through some of the telehealth referrals, because sometimes they probably don't need to be seen by a specialist, but unfortunately I always remind the surgeon that they need to be seen by somebody, and if we're not willing to see them, then it's a bigger problem we're creating. So sometimes you just got to bring a specialist back to reality and say, you know, obviously a bad referral is better than no referral, and I think patients just, they have no options, so that we need to see them.
Right.
So.
It's funny, you know, just hearing you talk about the critics out there who like love to criticize any new move being made, but the reality is like a lot of those people's input just ends there, right? Like, I'm here to criticize, but I'm not really here to offer solutions,
Yeah,
right? So
exactly.
I think everybody needs to take the critics with a little bit more grains of salt. Like, you know, Twitter and LinkedIn and everything provides everybody a platform, right?
Yeah.
And like everyone's opinions taken at face value, and everyone's opinions is looked at as equivalent. The reality is like they're not, and if people aren't really at the table in a meaningful way and offering solutions, like we should probably consider their opinions a little bit less. So
Unfortunately, there's always going to be the keyboard warriors out there that we can't control.
yeah. I know a couple.
As the resident Twitter,
Yeah,
famous Twitter
Follow me on Twitter.
guy, right? So yeah.
Jason Crid, at Jason Crid.
So I mean, you've done a lot in the last 24 months.
Yeah.
Build some different business lines, set up some processes that normally take a long time. For those that are listening that are interested in selling into the system, what type of advice would you give them to be successful?
I think the first part, especially in a public healthcare environment, you got to include the ministry or the health authority early in some of your discussions and ideas. I think they are willing to listen. Whether it take it to the finish line is, you know, a different conversation, but I think you got to include them early and get them on board. That'd be the first thing. And then when dealing with physicians, I think you really got to get some ideas and input from them to make it sound like it's their idea. If it's their idea, it's a really good idea. So, and then you can take it across the finish line. So I think if once you do that, I think it'll help a lot. So we, unfortunately, it's just how their mindset is. It's they certainly have massive amount of control in their environment,
right?
And so if you can kind of work with them and give them that piece of control, I think you'll go a lot further.
And maybe to go back to your first point about engaging whether it's the HA or the ministry or whoever it might be, I think everyone knows they need to do that, but they might not know how. So maybe as a larger organization that for you guys it might be easier.
Yeah.
What would you say for a smaller company that's just getting started? Like, how would they even go about doing that? Who do they talk to? Where do they start?
Phone a guy like you. Phone the consultants. I think that's it. Really, there's local people that are connected on the ground, and I think really just get in touch with them and then go from there. I think just a lot of just beating down doors.
Right.
Yeah, like cold calls work really well. There's not a lot of inbound cold calls of problem solvers to directors in the health authorities,
Sure.
and like I've done a lot of business with the health authority just by calling people and seeing if I can solve problems for them. And a lot of people might hang up on you or not even pick up or never call you back. But 1 in every 10 calls, you're going to get somebody who's excited and wants to work with the private system and kind of fed up with the status quo on the health authority side. And we did have like Graham Payette, who's director of innovation at Island Health. So he's always a good guy to reach out to if you want to trial something at Island Health.
Watch his inbox blow up now.
Yeah.
Sorry, Graham.
Graham.Payette.
I think the big thing too with that is these they're more interested in service related ideas and tech,
right.
As opposed to product.
Okay.
And I think that's just because there's always another Band-Aid, but really and truly like another service to make their lives easier, lack of a better word. I think they'll be more open to it.
And there's also Derek too. Like there also is like an NGO side too, long-term care, nonprofits that are operating healthcare organizations, and like they're always really willing to work with people too. And those organizations have a really good relationship with the health authorities too. So if you do good for one of those NGOs, they can definitely put in a good word and, you know, take you to that next level.
Yeah.
Awesome. Any other thoughts that we didn't cover that?
No, I think, you know, just speaking the rebalance type model, I think care needs to change locally and nationally and how it's done. I think the siloed specialists and siloed even GP I think that care is gone by the dinosaurs. I think physicians and care models have to change and include many different opportunities for patients, and in order to do that, they need to come together under one roof, and that's one thing that Rebalance has done exceptionally well. And now with Pulse, with the cardiology side, having it an option, because there's always an ailment that patient can be seen. If you can divert the patient at the triage stage, you know, really and truly the secret sauce for Rebalance is getting the patient in front of the right physician at the right time. So a non-surgical patient in triage should be triaged to a non-surgical physician, right, as opposed to, and same thing in all different facets. So if it's all about the triage, in my opinion. Even you can do that in the GP level. Someone that specializes in women's health or whatever it is, you can kind of triage them, and I think that's where it's important, where care needs to go.
What do you think from your side? You're also in the system.
Can you repeat the question?
Just any final thoughts, yeah. But I think tying into what Justin's saying about, you know, the care models, because you guys play a role in that.
Yeah. You know what? It's almost like everything's on fire, and it would be really hard to figure out what to put out first. Mm-hmm. I think, like, you know, just small adjustments to budget and like more of the same isn't going to fix these problems. I think there are probably jurisdictions that we can look to that like the Netherlands or Australia or the UK or France that have hybrid models. It's just clear what we're doing in Canada is not working. So I'd say, yeah, like we have to look to other jurisdictions, and like instead of just trying to reinvent the wheel here, let's go find a wheel that's working and like try to implement that. And let's not hold on to too many sacred cows, because that's only gonna like inhibit our ability to pick up new things.
Awesome.
Yeah. Right on.
That was great. Well, thanks for joining us.
Yeah,
thanks for
Chris.
dressing up.
Yeah, absolutely.
So I guess this does it for Health Tech Night episode 3. Thanks everybody for listening. And make sure to attend the next Health Tech Night. Whenever you are listening to this, it's going to be at Vancouver Island Life Sciences, which is near Uptown, March 16th.
Yes.
Yep.
Thursday.
Great. Right on. Sounds good.
All right.
Thanks for listening, everybody.